The title of this lecture is Anatomy of the Pleura. Here, the pleura, the sac around the lung. This lecture is by Professor Dr. Hany Waheeb Abdelmalek, Professor of Anatomy and Embryology at Shams University, Head of Combined Master's Degree Control at Shams University, and the former Vice Dean for Education and Student Affairs at Delta Faculty of Medicine. Learning outcomes. The student should be able to identify five learning outcomes. Number one, to define the pleura with its two layers, parietal and visceral. Number two, to outline the surface marking of the different parts of the parietal pleura, surface anatomy of the parietal pleura. Number three, to describe the pleural recesses, the two pleural recesses. What are the pleural recesses and their clinical importance? Number four, to correlate the nerve supply to the referred pain from the pleura, sites of referred pain in cases of pleurisy, inflammation of the pleura. Number five, to clarify the related clinical problems of the pleura, for example, hemothorax, pneumothorax, pleurisy, which is inflammation of the pleura, and pleural effusion. Introduction. What is the pleura? The pleura is a completely closed serous sac, which is invaginated from its medial side by the lung. So the pleura is a closed sac, which is invaginated by the lung from the medial side. The lung enters and enclosed within the medial side of this sac. The pleura has two layers: visceral layer, adherent to the surface of the lung, and the parietal layer, which surrounds the lung, and it is adherent to the thoracic wall, inner aspect of thoracic wall, and the upper surface of diaphragm, side of the mediastinum. It is the parietal pleura. Both layers, the visceral and the parietal, are separated by a potential space called the pleural cavity. To understand the idea of invagination of the lung through the medial side of the closed serous sac, which is the pleura, push your fist into an underinflated balloon. Push your fist into the side of a balloon. Your fist, which represents the lung, will be covered by the wall of the balloon, the visceral pleura, and the outer wall of the balloon will be the parietal pleura, while the cavity of the balloon will be the pleural cavity. So you push your fist into the balloon. The inner layer, which is adherent to your fist, is the visceral layer of the pleura. The outer layer is the parietal pleura, and the cavity in between is the pleural cavity. Here, this is the visceral layer of the pleura and the parietal layer of the pleura. The lung invaginates this closed serous sac from its medial sides and becomes inflated during the development, and the space in between the visceral and the parietal layers of the pleura becomes a potential space, which is the pleural cavity, like if you push your fist into the uninflated balloon. Here, the pleural cavity is a potential slit-like space. Potential slit-like space here in adult lung. The pleural cavity normally contains a small amount of tissue fluid. This is the pleural fluid, which covers the surfaces of the pleura as thin film and permits the two layers to move on each other with minimum of friction. So this thin film of serous fluid within the pleural cavity allows the two layers to move on each other without friction, with minimal friction. Again, here is the pleura with its two layers. Layer adherent to the surface of the lung is the visceral layer, and the outer layer, which line the surroundings and surround the lung, it is the parietal layer. Again, here is the pleura with its two layers, the visceral layer adherent to the lung, and the parietal layer. This is the outer layer, and in between is a potential slit-like space, which is the pleural cavity. The two layers of the pleura, parietal and the visceral, become continuous together around the root of the lung, the structures entering and leaving the hilum of the lung. And then for a short distance, below the hilum, the two layers form a fold of the pleura called the pulmonary ligament. So the two pleural layers become continuous with one another by means of a cuff of the pleura, cuff like the cuff of the sphygmomanometers, the device which measures the blood pressure. So this cuff is similar to the cuff of the device measuring the blood pressure. That surrounds the structures entering and leaving the lung, which are the bronchus, pulmonary vessels that form the root of the lung. So the two layers are continuous around the root of the lung, the structure entering and leaving the hilum of the lung, to allow for the movement of the pulmonary vessels and the large bronchi during respiration. So this cuff allows for the free movement of the structure within the root of the lung during respiration. This pleural cuff hangs down as a loose fold called the pulmonary ligament. So below the root of the lung there is a fold of the pleura called the pulmonary ligament, which also allows for the free movement of the structures within the root of the lung during respiration. Here, this is the cuff of the pleura around the root of the lung and the pulmonary ligament below the root of the lung. This is the pleura, pleural sac, and the pulmonary ligament. Here again, this is the medial surface of the lung, a cuff of the pleura surrounding the structures within the root of the lung, structures entering and leaving through the hilum of the lung, and for a short distance, the two layers form the pulmonary ligament. Pulmonary ligament and this cuff allows for the free movement of the structures within the root of the lung during respiration. So the layers of the pleura has two layers. First layer is the visceral or the pulmonary pleura. This layer is adherent to all surfaces of the lung and extends into the lung fissures. It is absent at the hilum of the lung. This is the bare area of the lung. The area of the lung, the area which is not covered by the visceral pleura, it is the hilum of the lung. So the visceral or the pulmonary pleura is adherent to all surfaces of the lung. Second layer is the parietal pleura. Parietal pleura, it is the outer layer of the pleura. The parietal pleura has four parts. It is divided into four regional parts according to the region. First, the cervical pleura, which extends for 2.5 centimeters above the clavicle. This is the summit of the pleura. Second, the costal or costovertebral pleura, which lines the thoracic wall and the costal cartilages and sides of the vertebrae. Number 3 is the mediastinal pleura, which covers the side of the mediastinum. Number 4, diaphragmatic pleura, which covers the upper surface of the diaphragm. So the parietal pleura has four regional parts: cervical, costal, mediastinal, and diaphragmatic. Number 1, cervical pleura or dome of the pleura. This is the summit of the pleura, highest point of the pleura. It extends over the apex of the lung and bulges up through the inlet of the thorax into the root of the neck. So it is a part of the pleura which extends into the root of the neck and covers the apex of the lung. Relations of the cervical pleura, also these relations apply to the apex of the lung. It is closed anteriorly by subclavian artery. So the anterior relation of cervical pleura is subclavian artery. It is related posteriorly. This is the posterior relation to the cervical pleura and the apex of the lung. Related posteriorly to three structures in front of the neck of the first rib. From medial to lateral side, these structures are arranged as stellate ganglion. This is the cervicothoracic ganglion, last cervical sympathetic ganglion fused with first thoracic sympathetic ganglion. It is called stellate. It resembles a stellate. It is stellate-like, star-shaped. Then the superior intercostal artery, which is a branch from subclavian artery, and ventral ramus of first thoracic nerve. So the three structures in front of the neck of the first rib, behind the cervical pleura, from medial to lateral are stellate ganglion or cervicothoracic ganglion, superior intercostal artery, and the ventral ramus of first thoracic nerve. It is covered by a fan-shaped, tough suprapleural membrane called septum fasciae. So, the superior relation of cervical pleura is septum fasciae or suprapleural membrane. This membrane is attached laterally to the inner border of the first rib and medially to the 7 cervical transverse process. So the septum fascia or suprapleural membrane is a fan-shaped membrane which extends from the inner border of the first rib laterally to the tip of the transverse process of 7 cervical vertebra medially. Again, the relations of the cervical pleura here, it is related anteriorly to subclavian artery, posteriorly to the neck of the first rib, with 3 structures in between. From medial to lateral are stellate ganglion, superior intercostal artery, and ventral ramus of first thoracic nerve. Superiorly, it is covered by septum fascia or suprapleural membrane. Here, the septum fascia or supramembrane extends from the inner border of the first rib laterally to the tip of the transverse process of 7 cervical vertebra medially. It is a tough fibrous membrane covering the cervical pleura. Second part of the parietal pleura is costal or costovertebral pleura. This part of the parietal pleura lines the inner wall of thoracic cavity. It lines the ribs, costal cartilages, intercostal spaces, and the sides of the vertebral bodies in addition to the back of the sternum. So it is a part of the parietal pleura adherent to the inner aspect of thoracic wall and the sides of the vertebrae. It is separated from the thoracic wall by a thin layer of loose connective tissue called endothoracic fascia. So in between the costal pleura and the ribs and the intercostal spaces is a thin layer of loose connective tissue called endothoracic fascia. Number 3, the mediastinal pleura. It is a part of the parietal pleura which covers the side of the mediastinum. This is number 3, mediastinal part of the parietal pleura which covers the side of the mediastinum. Again, it is continuous with visceral pleura around the hilum of the lung for a short distance below it, where it forms a fold called the pulmonary ligament. So this part of the parietal pleura, mediastinal pleura, it is the part which forms a cuff around the root of the lung with the visceral pleura, and it is the part which forms the pulmonary ligament with the visceral pleura. Number 4, the last part of the parietal pleura is diaphragmatic pleura, which part of the parietal pleura covering the upper surface of the diaphragm. Again, the 4 regional parts of the parietal pleura include cervical pleura, dome of the pleura, and costal or costovertebral pleura, which lines the inner aspect of thoracic wall, mediastinal pleura, which covers the side of the mediastinum, and the diaphragmatic pleura, which covers the upper surface of the diaphragm. What are the pleural recesses? Pleural recesses are parts of the pleural cavity which become wide during expirations, and it is filled by the lung during inspiration. There are 2 recesses along the margins of the parietal pleura. The lungs don't completely fill the anterior or the inferior regions of the pleural cavities. Here the anterior regions and here the inferior region. The lungs don't completely fill these regions. This results in formation of 2 recesses. Number 1, it is called the costomediastinal recess of the pleura. Number 2, it's called costodiaphragmatic recess of the pleura. So the pleural recesses are formed between the adjacent layers of the parietal pleura. Expansion of the lungs into these spaces usually occurs only during forced inspiration. So the lung becomes fully inflated to enter into these spaces during forced inspiration. The recesses also provide potential space in which fluids can collect and aspirated. Fluids within the pleural cavity could be collected in these 2 recesses and could be aspirated from them, like the hemothorax or hydrothorax or pleural effusion. These are a collection of fluids within the pleural cavity. These fluids are collected within these 2 recesses and could be aspirated. First, the costomediastinal recess. This is number 1. Costomediastinal recess is present on each side. It is present along the anterior margin of the pleura. So anteriorly, costomediastinal recess is present on each side at the junction between the costal and the mediastinal pleurae. The largest is present on the left side in the region overlying the heart. So costomediastinal recesses are present on each side, but it is larger on the left side in the region overlying the heart. This recess is present between the costal and the mediastinal parts of the parietal pleura along the anterior margin of the pleura. The second recess is the recess present along the inferior margin of the parietal pleura. It is largest and clinically the most important recess are the costodiaphragmatic recesses, which present in each pleural cavity between costal pleura and the diaphragmatic pleura along the inferior margin of the pleural sac. The costodiaphragmatic recesses are regions between the inferior margin of the lung and the inferior margin of the pleural cavities. So it is the space between the inferior margin of the lung on each side and the inferior margin of the pleural cavities on each side. They are deepest after forced expiration, because in forced expiration the inferior margins of both lungs are raised upward, leaving a larger part of the space below them, and these recesses become shallowest after forced inspiration because the inferior margin of the lung enters into these recesses during forced inspiration. So the costodiaphragmatic recesses are deepest in forced expirations and the shallowest in forced inspiration. The inferior borders of the lungs enter into these recesses in forced inspiration. Just a break. We take a quiz. Which one of the following structures is related to the anterior surface of cervical pleura? The anterior relation cervical pleura, also it is the anterior relations of the apex of the lung. Which one of these structures is anterior to cervical pleura? Number A, superior intercostal artery. Number B, first thoracic nerve. Number C, septum fascia. Number D, subclavian artery. Superior intercostal artery, first thoracic nerve are posterior to the cervical pleura and the apex of the lung. Septum fascia is superior, it covers the cervical pleura, while subclavian artery is anterior to cervical fascia and the apex of the lung. So the correct answer is number D, subclavian artery. Number 2, enumerate the 4 regional parts of the parietal pleura. What are the 4 regional parts of the parietal pleura according to the region? Correct. Cervical pleura, it is the dome of the pleura. Costo or costovertebral pleura, laterally, and mediastinal pleura, medially. The diaphragmatic pleura, which covers the upper surface of diaphragm inferiorly. So there are 4 regional parts of the parietal pleura. Nerve supply of the pleura. Nerve supply, blood supply, lymphatic drainage of the pleura. Parietal pleura is always with Zeus of the thoracic wall, while visceral pleura is always with Zeus of the lungs. So the nerve supply of the pleura, parietal pleura, is supplied by somatic nerves, nerves of thoracic wall, and therefore it is sensitive to pain, temperature, touch, and pressure. The parietal pleura is sensitive to somatic sensations like pain, temperature, touch, and pressure. It is innervated by somatic nerves. The costal and the peripheral parts of diaphragmatic pleurae supplied by intercostal nerves, while the mediastinal and central part of diaphragmatic pleurae supplied by phrenic nerve. Again, the costal and the peripheral parts of the diaphragmatic pleurae supplied by intercostal nerves, while mediastinal and central part of diaphragmatic pleura supplied by phrenic nerve. Parietal pleura innervated by somatic nerves with thoracic wall, sensitive to somatic sensations, while the visceral pleura is supplied by the autonomic nerves derived from anterior and posterior pulmonary plexuses like the lung. It is innervated by autonomic nerves from the anterior and the posterior pulmonary plexuses, and it is sensitive to stretch. It is sensitive to visceral sensation, stretch. Here is the nerve supply of the pleura. The costal pleura and the peripheral parts of diaphragmatic pleurae are supplied by intercostal nerves, while the mediastinal pleura and the central part of diaphragmatic pleura are supplied by phrenic nerve. Both phrenic and the intercostal nerves are those of thoracic wall, they are somatic nerves, while the visceral pleura adherent to the lung is innervated by autonomic nerves from the anterior and the posterior pulmonary plexuses like the lung. Blood supply of the pleura, again, blood supply of the parietal pleura with thoracic wall, and the blood supply of the visceral pleura with the lung. So, the parietal pleura is supplied by vessels of thoracic wall, which are intercostal artery, internal thoracic, and the musculophrenic blood vessels. The internal thoracic, internal intercostal, and the musculophrenic vessels, those of the thoracic wall. While the visceral pleura is supplied by bronchial arteries and drained by bronchial veins like the lungs. Visceral pleura supplied by bronchial vessels, while parietal pleura supplied by vessels of thoracic wall, which are the intercostal, the internal thoracic, and the musculophrenic vessels. Finally, the lymphatic drainage. Those of the parietal pleura with thoracic wall, those of visceral pleura with the lung. So the lymphatic drainage of the parietal pleura joins those of the thoracic wall, draining into the intercostal lymph nodes, parasternal lymph nodes, posterior mediastinal, and the diaphragmatic lymph nodes of thoracic wall. Intercostal, parasternal along the internal thoracic artery, vessels, artery and vein, and the posterior mediastinal in the posterior part of the intercostal spaces, and the diaphragmatic lymph nodes. Lymphatics of the visceral pleura join those of the lung into the bronchopulmonary lymph nodes. So lymphatics of parietal pleura drain into the lymph nodes of thoracic wall, while lymphatics of the visceral pleura drain into the lymph nodes at the hilum of the lung, with those of the lung, the bronchopulmonary lymph nodes. Here, the bronchopulmonary lymph nodes draining visceral pleura, while other lymph nodes of the thoracic wall drain the parietal pleura. Applied anatomy. Inflammations of the parietal pleura is called pleurisy. If the parietal pleura becomes inflamed, it's called pleurisy, while inflammation of the lung is called pneumonia. So pleurisy, inflammation of the pleura, produces severe pain, which is referred to according to the nerve supply. If the thoracic, if the costal and the peripheral parts of the diaphragmatic pleura are inflamed, these parts are supplied by intercostal nerves. So the pain referred to thoracic and the abdominal walls. And if the mediastinal and central part of the diaphragmatic pleura are inflamed, innervated by phrenic nerve, this pain referred to the lower neck and the shoulder tip. If the mediastinal and central part of the diaphragmatic pleura are inflamed. So inflammation of the pleura is called pleurisy. It produces severe pain referred to thoracic and the abdominal walls. If the costal or peripheral diaphragmatic pleura are inflamed, these parts are innervated by intercostal nerves. And the pain is referred to the lower neck and shoulder tip. If the mediastinal and central parts of the diaphragmatic pleura are inflamed, these parts are innervated by phrenic nerves. To continue the applied anatomy. In certain diseases like the pulmonary tuberculosis, TB, or chest injuries, penetrating wounds into the thorax, the pleural cavity may be filled with types of fluids, or air may be collected into the pleural cavity. If air is collected, in case of penetrating wounds of the thoracic wall, this condition is called pneumothorax. Pneumothorax. Pneumo means air. If the pus is collected, the condition is called empyema. Empyema plus pus collections into the pleural cavity. If both air and pus, the condition is called pneumothorax. If the blood is collected, the condition is called hemothorax. And finally, if exists serous fluid is collected, serous exudate, this condition is called hydrothorax or pleural effusion. This image for the aspiration of the fluids from the pleural cavity. So again, if there is in certain diseases like tuberculosis or chest injuries, penetrating wounds into the chest, the pleural cavity may be filled with air, a condition of pneumothorax, pus, condition of empyema, air and pus, condition of pneumothorax. If the blood is collected, the condition is called hemothorax. And if exists serous fluid is collected, serous exudates, the condition is called hydrothorax or pleural effusion. Surface anatomy of the pleura. What is the surface anatomy? Cervical pleura represented by a curved line from the sternoclavicular joint to the junction of the medial and the middle thirds of the clavicle. It extends for 2.5 centimeter above the medial third of the clavicle. Its summit is 2.5 centimeter above medial third of the clavicle. So the apex, the cervical pleura, dome of the pleura, is represented by a curved line from sternoclavicular joint to the junction of the medial and the middle thirds of the clavicle, extends for 2.5 centimeter above the medial third of the clavicle. Anterior margin of the pleura differs between both sides. It extends from the summit of the pleura 2.5 centimeter above the medial third of the clavicle. Then extends downwards and medially to sternoclavicular joint, then downwards and medially to meet in the middle line behind the sternal angle. Again, from the dome of the pleura, cervical pleura, 2.5 centimeter above the medial third of the clavicle, downwards and medially to sternoclavicular joint, then down to the midline to meet together behind the sternal angle. From the sternal angle, the right and the left anterior margins of the pleura descend in contact with each other down to the level of the fourth costal cartilage. So down to the level of the fourth costal cartilage, the anterior margins of both pleurae are similar, extending from dome of the pleura to the sternoclavicular joint, to the sternal angle, then vertically down close to the middle line, down to the fourth costal cartilage. Below the fourth costal cartilage, anterior margin on both sides differ from each other. On the right side, it continues vertically down to the back of the xiphisternal junction, nearly at the level of 6th costal cartilage. So on the right side, continues vertically down to the level of the xiphisternal joint. While on the left side, the anterior margin of the pleura deviates laterally and descends at a distance of 2 to 2.5 millimeter from the left margin of the sternum down to the level of the 6th costal cartilage. It forms slight deviations on the left side from the level of the 4th down to the level of the 6th costal cartilage. The inferior margin of the pleura passes through these ribs 8, 10, and 12. Remember these numbers 8, 10, and 12. While in the lung, the inferior margin will pass through the ribs 6, 8, and 10. Two ribs smaller, two ribs upper than those of the pleura. So the inferior margin of the pleura begins at the 6th costal cartilage at the end of the anterior margin of the pleura, then descends infralaterally to cross 8th rib in mid-clavicular line. It crosses the 8th rib in the mid-clavicular line. Then crosses the 10th rib in the mid-axillary line, then the 12th rib in the mid-scapular line posteriorly, here posteriorly, to end 2 centimeter lateral to the 12th thoracic spine. Again, inferior margin of the pleura passes through 8th rib in mid-clavicular line, 10th rib in mid-axillary line, 12th rib in mid-scapular line, and ends 2 centimeter lateral to the 12th thoracic spine. The posterior margin of the pleura extends from the medial end of the inferior margin, which is 2 centimeter from the T12 spine. It extends vertically up along the vertebral column to reach the spine of 7th cervical vertebra. So the posterior margin extends from the spine of the 12th thoracic vertebra up to the spine of 7th cervical vertebra along the vertebral column. Note, the deviation of the anterior margin of the left pleura results in direct contact of the pericardium and the heart with the left part of the sternum and the parts of the left 5th and 6th costal cartilages, with no pleural cavity in between. So these parts are called bare area of the pericardium, the part of the pericardium in direct contact of thoracic wall without pleura in between. This part is related to the left part of the sternum and the parts of the left 5th and 6th intercostal spaces and the costal cartilages. That facilitates puncture of the pericardial cavity. If you want to aspirate fluids from the pericardial cavity, so we could introduce the needle through these parts without injuring the pleura. Here again, this is the bare area of the pericardium, the part of the pericardium directly related to the thoracic wall without intervening pleura. These parts are the left parts of the sternum and the parts of the left 5th and the 6th costal cartilages. Here the surface anatomy of the pleura and lungs. Note that the inferior margin of the lung is 2 ribs above the inferior margin of the pleura. Clinical case. A 60-year-old man went to hospital complaining of shortness of breath. It has dyspnea, chest pain referring to the lower neck, and the cough. The patient told his doctor that he had an attack of fever and bronchitis 1 week ago. The doctor examined his chest and found diminished breath sounds. He recommended an urgent chest X-ray. The doctor noticed an obliteration of the right costophrenic angle in the X-ray. This is the pleural effusion in the costophrenic angle. He ordered thoracentesis, aspiration of the fluid. Thoracentesis means aspiration of the fluid. So, first question. What is the most likely diagnosis case? It is a case of pleural effusion. There is obliteration of the right costophrenic angle. Accumulation of exudate, serous exudate within the costophrenic angle. It is a case of pleural effusion or hydrothorax. The inferior margin of the pleura in the mid-axillary line is at the level of, here the surface anatomy, inferior margin of the pleura mid-axillary line reaches to the 10th rib, while if the inferior border of the lung, it reaches to the 8th rib. So it reaches to the level of the 10th rib. Mention another site where the pain could be referred. So here we will notice that the condition was on the right side. Obliteration of the right costophrenic angle, right. So, and the pain is referred to the lower neck. So what other site? This condition means inflammation, pleurisy of the mediastinal and central part of the diaphragmatic pleura innervated by phrenic nerve. So the other site is the tip of the right shoulder. Tip of the right shoulder. What are the possible fluids that may accumulate in the pleural cavity other than hydrothorax? If pus, empyema, air and pus by pneumothorax. If blood, hemothorax, and if exists serous fluid, it is hydrothorax or pleural effusion. Dear students, my best wishes, Dr. Hany Waheeb.